So very warm welcome to everybody to the Gynae Endocrinology Symposium. I met a lot of people outside asking कि मैं gynecologist endocrinology symposium में क्या कर रही हूँ. I think a lot of us still don't understand that gynae and endocrinology are linked, that we also see patients who have endocrinological problems and we need to collaborate. So we'll be discussing a lot of important scenarios including thyroid disorders, hyperprolactinemia in young girls trying to get pregnant or during pregnancy, then dealing with puberty menorrhagia, secondary amenorrhea, diabetes during pregnancy. So these are a lot of factors where gynecologists and endocrinologists need to collaborate. Without any further delay, we'll start off with the first session. And to chair this, I would like to invite on the stage Dr. Rekha Mehra. Ma'am, are you here? Dr. Neeru Kiran. Good afternoon, ma'am. And Dr. Neeru Thakral. Good afternoon, ma'am. I think we met in the last SPEEDCON 2 years ago. So we get to meet here once in a year. And our first speaker for today is Dr. Bindu Kulshreshtha. Is Dr. Bindu here? Yeah. So she'll be talking about an 18-year-old girl with secondary amenorrhea for 5 months and hirsutism.
Thank you. Before I start, I'd like to thank the organizers for giving me this opportunity to interact with you all. So, recently a patient came back to us. She was 21 and though not 18, but I'll be discussing about that patient. So this patient, 19-year-old, she had menarche at 13 years. She's complaining of irregular periods for the past almost 2 years. She's totally amenorrheic for the past 6 months. She's been advised medroxyprogesterone acetate for 10 days, with which she has had a bleed. She's been having acneiform eruptions for the past 5 years, hirsutism for 5 years. Her father, family history is significant for a father having coronary artery disease. He's now 65 years, and the mother is hypertensive too. She is lean, BMI of 22.7 kilogram per meter square, normotensive. She has a Ferriman Galloway score of 11. Her acne has been classified as moderate by the dermatologist. There are 1 or 2 pustules and there are 15 acneiform eruptions. So basal hemogram, liver functions, kidney functions are normal. She has normal thyroid profile and prolactin. Her LH to FSH ratio is more than 2. Her testosterone is 1.6 nanomole per liter. DHEA, 17-OHP, other androgens are normal. She has normal glucose fasting and PP values. However, her insulin fasting is 10 and insulin postprandial is 101. Her lipid profile is not available. Her ultrasound has been, they have not given the number of cysts in the ovaries, but the radiologist has given a report of bilateral polycystic ovaries. We classify the patient as PCOS and we start her on OCP, but she is worried about the side effects. So whether we have done right or not and how to approach this case, I'll be discussing. So for PCO diagnosis, there are mainly 3 components: hyperandrogenism, polycystic ovaries, and chronic anovulation. And if you have any 2 of these 3, the patient could be having PCOS. Our patient has all these 3 components. However, it is a diagnosis of exclusion, and therefore we have to exclude androgen-producing tumors from the adrenals and ovaries, congenital adrenal hyperplasia, hypothyroidism, hyperprolactinemia, acromegaly, and Cushing's. So therefore, we end up doing a lot of tests because it's a diagnosis of exclusion. History. When we are seeing a patient with hirsutism and irregular periods, it's very important to know that how the hirsutism has progressed. So if hirsutism and very marked hirsutism has come within a short span of time, it is associated with a change in voice and total absence of periods, we could be dealing with something like androgen producing tumors. So the history is important. If hirsutism comes prepubertally, there's usually some pathology to it, something like congenital adrenal hyperplasia. Also ask for features of hyperandrogenemia like alopecia or acneiform eruptions. Our patient also had acneiform eruptions. It's important in peripubertal ages to know for the progression of puberty. Important to ask the history for changes in weight, especially as I said earlier, that something like you may be dealing with Cushing syndrome, and ask for presence of stria in the patient. History of drugs producing hirsutism and irregular periods is important. Also ask for history of galacturia because hyperprolactinemia can present in this way. Psychosocial issues are very important to address because how much are they distressed with hirsutism and irregular periods. Also, the most common cause is PCO, so important to ask for a family history of androgen excess or a history of type 2 diabetes or hypertension. Physical examination, very important, is anthropometric measurements, skin for signs of acne, androgenic alopecia, acanthosis nigricans, a marker of insulin resistance, and excess scoring of body hair by Ferriman-Galloway score. Very important to look for signs of virilization and have a careful look at the genital examination for clitoromegaly and any antenatal evidence of androgen excess. Look for galacturia and features of any Cushing syndrome. So here in the first photograph, we can see a family, a 15-year-old girl. The young child is about 2 years of age. He had, the child was reared as a female, had genital ambiguity, and this genitalia just below this thing is showing clitoromegaly, and there is single opening. This indicates that this patient has evidence of antenatal androgen excess, and she was diagnosed as a case of congenital adrenal hyperplasia. Another patient, similar patient, 18-year-old, she had hirsutism, and we can look moon faces, and she had abdominal striae too. So the second photograph is that of a Cushing syndrome. The third is taken from somewhere else, and this patient had clitoromegaly, and we can see marked hirsutism on the face. This patient had androgen secreting tumor of the ovary. So investigations accordingly, because we are ruling out all prolactin, thyroid, 17-OHP, ONDST if we are looking for Cushing syndrome. A GTT and lipid profile is important because PCO patients are prone to develop metabolic syndrome. LH-FSH, look for LH-FSH ratio. Amongst the androgens, the total testosterone is most important. In PCO, if the total testosterone is normal, then we need to look for free testosterone or sex hormone binding globulin. Also look for other androgens like DAS and androstenedione because there may be 10 or 20% cases of PCO who may be having only DAS elevation. Also important is to look for adrenal or ovarian imaging, especially if we are looking for tumors in these locations. So how do we define hyperandrogenemia? The method of estimation, there's usually an overlap in the normal values, especially in PCOS. So a high normal female value is what is seen in PCO. These are, and it's always suggested that you have your own labs. So this is one of the DST sponsored study that we did on 99 controls. And these are the cutoffs we are using for testosterone. More than 1.55 nanomole per liter, and free testosterone of more than 4.55 picogram per ml at our institute. The hormonal estimation it's advised is to do in the early follicular phase, especially 17-hydroxyprogesterone because of the progesterone formation in the luteal phase. Most of the labs perform direct methods without any extraction, but what is recommended is immunoassay after extraction and chromatography. The gold standard is equilibrium dialysis and tandem mass spectrometry. So if the serum testosterone is very high, more than 2 nanogram per ml, it usually indicates that you are dealing with either an adrenal or ovarian tumor. DAS more than 700 microgram per dl could suggest an adrenal tumor. It's important, as I said, to do 17-OHP in the follicular phase. If it is more than 2 nanogram per ml, you go in for an AC-rate stimulated 17-OHP levels. And if more than 10 nanogram per ml, it indicates a non-classic congenital adrenal hyperplasia. Dexamethasone suppression test may be done if required. If you're thinking of acromegaly, the patient has acromegaly-like features, you can go in for IGF-1 and growth hormone suppression tests. So Ferriman-Galloway scoring, as we know, that it is basically 9 areas that we score: upper lip, chin, breast, upper abdomen, lower abdomen, upper arms, upper thigh, upper back, and lower back. So they are given a scoring from 1 to 4. So what is a cutoff? Scores of more than 8 or more than 5 have been commonly accepted as abnormal. Our patient had Ferriman-Galloway score of 11, so it's mild hirsutism. However, people have said that it is important to look at what patient feels. Sometimes the patient may not have that cutoff, but the patient has developed facial hair. So we need to address patient-important hirsutism. The Ferriman-Galloway score has been criticized because it gives the same scoring to the face and arms, and it also depends on ethnicity. In China, a Ferriman-Galloway score, the cutoff is 2. In India, we do not have any norms. So people have also suggested that you could only do a upper lip, chin, or lower abdomen if you do not want to expose the patient. How do we define polycystic ovaries? Now, traditionally in the Rotterdam criteria, it's been conventionally defined as 12 or more follicular count, measuring 2 to 9 millimeter in diameter, or an increased ovarian volume of more than 10 ml. However, what is also advised is transvaginal ultrasound, and with sensitive transducers. Now it is suggested, the endocrine recommendations are that the threshold for polycystic ovarian morphology should be a follicular number more than 20 or an ovarian volume more than 10 ml. We do not have a data from India. Again, data from China indicates no, they still have a cutoff of 12 or more. Data from India we do not have. So in adolescence, because you can't do a transvaginal ultrasound, you go in for transabdominal ultrasonography, and you use mainly a ovarian volume criteria. And because follicular count measurement becomes unreliable with this methodology. So what are the therapies that we give? There are mainly 3 kinds of drugs that we give. We give oral contraceptives to patients with PCOS. We give anti-androgens, and we give metformin. We try to break away the hyperinsulinemia, hyperandrogenemic pathway at this stage. And the endocrine guidelines suggest that hormonal contraceptives are the first line of treatment for hirsutism and regularization for cycles, and anti-androgens should be added if there is a suboptimal response after 6 months. Local methods for mild hirsutism may be given. Metformin may regularize periods, but it has modest effects on hirsutism. It is only preferred if a patient has IFG or IGT. So oral contraceptives, as we know, are the most effective. They act by inhibiting gonadotropins, and they increase SHBG. The Endocrine Society does not prefer one oral contraceptive over another. They could be protective for endometrial carcinoma. However, one concern always remains that they can worsen the metabolic syndrome. PCOS patients are already prone to metabolic syndrome. Another important class is anti-androgens. We are commonly using spironolactone in doses of 50 to 100 milligram per daily. It's an androgen receptor blocker, steroid synthesis inhibitor, and an anti-aldosterone also. Another anti-androgen that is used is finasteride. Flutamide is not used because of liver toxicity. However, we do not know what is the effect of spironolactone in metabolic syndrome. Some patients may develop menstrual abnormalities with anti-androgens. It is possibly not preferred. This is what the usual perception is, that if the patient has IFG or IGT, you would not give spironolactone. You do not know what is the effect on periods, and it is contraindicated when pregnancy is desired. Now, for hirsutism, this is a review which has almost 4 randomized studies, and it does indicate that it is spironolactone in the doses of 50 to 100 is effective in reducing the Ferriman-Galloway score. And we have 2 studies whereby they say that they improve the menstrual cyclicity also, 6.6 per year to 10.2 per year. Another study which said that it almost normalized the menstrual cycles. Now here we have a patient with severe hirsutism, almost a beard is there. The community that she comes in, she does not want to remove her hair, and this patient was given oral contraceptives plus anti-androgens both, and this is after 2 years. There is some clearing. She refused to use any local method. Now, The third class is the insulin sensitizers, metformin. It increases the insulin sensitivity. It inhibits androgen synthesis, and thereby it is effective in PCO. It definitely has favorable effects on metabolic syndrome, on obesity, and it also regularizes the periods. But the problems rise that it has very modest effects on hyperandrogenism. So our patient had prolonged period of amenorrhea, more than 6 months. She had significant acne, moderate. 1 or 2 lesions were purulent also. She has mild hirsutism and she has hyperinsulinemia. So going by the Endocrine Society guideline, we started her on oral contraceptives. Now let's see what really happened. So she took oral contraceptive for 5 months. Her weight was 55 kg, decreased to 53 kg. She developed regular cycles. Her chin hair reduced, but she said that her acneiform eruptions had increased or almost the same. She was not convinced with the medication that we were giving. And we did not have a baseline lipid level, but our lipid levels at 6 months were total cholesterol 347, LDL cholesterol 317, HDL 52, TG 151. When she came to us 6 months later, she had already stopped the medication for 20 days and she said, I do not want to take the OCP. Her father has had a CAD, if you remember, and so oral contraceptive and acne. Now when the oral contraceptive are given as contraception, most of them in the leaflets have acne as a side effect, and it is due to progestogens which may be having androgenic properties. So the acne can occur paradoxically with the use of some oral contraceptive, and this is due to particular sensitivity to the type of progestin. But in our case, we were giving oral contraceptive which had drospirenone, which is known to have anti-androgenic activity. In a recent Cochrane review, for acneiform eruptions also, the OCPs are known to be very effective in almost 90% of the women in most series. So what are the other factors which could have contributed to her, worsening of acne? Diet, lifestyle. Yes, she was stressed, she was unable to sleep for a few months, and there were some personal factors that she was dealing with. But of course, oral contraceptive, I could not come across case reports whereby drospirenone was implicated for increase in acneiform eruptions. So her main worry was about the metabolic syndrome. So what does the data indicate? Now, most of the observational studies which have been done have given varied kind of answers. Some have shown a deteriorating metabolic control. Some have shown no effect. Some have shown improved effect. A recent Cochrane review compared OCP versus metformin in PCO patients, identified only 4 RCTs involving 104 patients with a study duration of 6 to 12 months. So we do not truly have long-term data. So though it concluded there is no adverse metabolic risk, we do not have data beyond 2 years. Metformin is definitely effective in metabolic syndrome. Now a patient had a lipid profile which was really frightening. So OCPs are known to increase the triglycerides. PCO patient already have high triglyceride and low HDL cholesterol level. There are some studies, again, on discrepant kind of data. Some studies indicate that it may increase the LDL cholesterol, increase the HDL cholesterol also. So some researchers have argued that when there is a low LDL to HDL ratio, it may not be counterproductive. But there are also studies saying that when you are giving OCPs to your PCO patient, there could be increased carotid media thickness. So another review, human reproduction uptake, so which basically says that if you use COCs, oral contraceptives with metformin, you can address some of the metabolic issues. So what about spironolactone? Earlier I had put a query as to we truly do not know what it does on glucose tolerance or the lipid profile. We've seen with the data that it has good effect on hirsutism, possibly improves the cycles also. It is an anti-mineralocorticoid, glucocorticoid, anti-androgen and anti-inflammatory activity. And there are studies indicating that it also improves the insulin sensitivity by blockade of aldosterone, and these are the 2 in vitro studies which indicate that. So there was a study by Dr. Ashraf and Dr. Amini who've done work in this area whereby it showed that, even spironolactone is reducing the insulin levels. I further did, along with Dr. Amini, under Dr. Amini, another retrospective studies whereby we had some patients with IFG also in spironolactone group, and there also there was improved in the insulin sensitivity. So here, after I came to Ram Manohar Lohia Hospital, this is another study of about more than 100 patients, and whereby we are seeing that, the insulin levels at towards to go down, and at least in the lipid profile, there is not much change. It is not counterproductive like oral contraceptives. So our patient does not want to take OCP. She's constantly talking about dyslipidemia. She's worried about acne also. Now, if we give spironolactone, I'm worried that the patient has 6 months amenorrhea. I do not think that I'll be able to do it with spironolactone alone. Metformin has modest effect on hirsutism. So a combination of anti-androgen and metformin has been tried, and it basically says that a combination of metformin and spironolactone is superior to either drug alone. And there are studies of acneiform eruptions in spironolactone also, whereby the spironolactone has worked quite well in patients with acneiform eruptions. Lifestyle modification, we want to talk to the patient. She's stressed, her diet may be erratic, and we are addressing those components. And look at what we start her on aldactone and metformin 50 milligram per day, and metformin of only 500 mg per day. So the first of last March of 21, her periods were regular on OCPs, you remember, and we start her on rosuvastatin, only 10 milligram also. But she comes 5 months later, her periods are regular on spironolactone and metformin after 5 months of therapy. LDL cholesterol has come down, and we increase the dose of rosuvastatin, and we can see the last value almost a year down the line. Her lipid levels have shown remarkable improvement. So one of our studies whereby, is it always the case? So we've published some data, very small study, 48 patients who had been on oral contraceptive for 2 years. So 75% had regular cycles over a period of 1 year with non-hormonal options like spironolactone and metformin. But the patients who continued to require OCP had a greater duration of menstrual irregularity. So if they had more than 6 months of amenorrhea, they did not respond. I'm glad our patient did respond. So concluding, for PCO, oral contraceptives are the first choice, no doubt. That's what the Endocrine Society says. It is effective both for hirsutism and anovulation, but a healthy lifestyle is very, very important. The management could be individualized, basically addressing the concerns on cardiovascular safety. Metformin and anti-androgens are also an option, or a combination could be a choice if OCPs do not provide a satisfactory response. Thank you.
Thank you, Dr. Bindu, for excellent case discussion.